step is ideally next step probably, at some point we're going to talk about labs as well. But as far as imaging, what are you looking for in this particular case in someone coming in with a painful total knee? What are you looking for? And actually, I recently read an article that I thought was very good. Can't really remember who wrote it. I think it was like 2014. And author name was Kumar, but it was about things to look for in a post-op total knee. And can we just kind of mention that as well? Because I could see how they all could play a role. Things that you're looking for anytime after you do a total knee arthroplasty, and things that you may highlight a little bit more when they're having pain.
Yeah, and spend as much time as you want on this, because I think this is really important to be able to kind of evaluate X-rays and know what you're looking for and know when something's wrong.
Yeah, I agree. I think X-rays can tell a lot about how a surgery went and whether or not there was a struggle and how a patient's doing. So they don't tell the whole story, but they certainly tell the story. And I think that critical evaluation of X-rays, your own and other people's, are a huge part of evaluating these patients. So the first thing I look at is I know these are usually short-legged X-rays. Not everybody gets a scanogram on everyone. I typically do not get a scanogram unless I see that there's some sort of a major alignment issue on exam, or if I see they've got some anatomic variation on their short-legged X-rays, I'll get a scanogram on the initial visit, but I won't always get that on people. But if you just look for overall alignment, make sure that on the X-ray, if it's weight-bearing, you can see if there's balance or even polyethylene wear. You should not see significant gapping on one side or the other. It can be indicative of poor balancing or asymmetrical polyethylene wear. Really, you shouldn't see a lot of overgrowth around the sides of the component. So it's harder to see on the femur, but on the tibia, you'll see if someone has a loose component, you kind of want to look where the implants are relative to the regular bony landmarks. So primary total knee replacement, the depth of resection should not be below the fibular head, the tip of the fibula. So if you see somebody and they've got what looks like what you think might be heterotopic ossification or bone overgrowth that people talk about around the lateral side of the tray, and the level of the thought that the level of resection is below the tip of the fibula, that implant's probably loose, and it's actually subsided. It's not bone overgrowth, but rather the implant is plowed into the lateral plateau. So I look with respect to other bony landmarks. You look at the joint line. Different, from the medial epicondyle, you want to make sure that you can see if the femur's loose. That's mostly on the AP. You can look at those sorts of things. And then you want to look for things, especially in an older knee like the one we see here. There's no significant polyethylene wear that you can see, but you can see, a geographic lesion that you can draw your finger around, and that proximal tibial metaphysis, indicative of significant osteolysis. You can see it in the femur as well. Now, these implants don't appear loose to me, but for sure, this osteolysis causes synovitis, and that osteolysis can be painful. So, these are reasons that can explain the patient's pain.
And when you say appear loose, what do you mean? What do you mean by that? What on the X-ray would show you? Okay, well, this implant appears loose. Like you see the osteolysis, but
yeah, I think for testing purposes, they would either have to show you an implant that is just grossly malpositioned with regard to normal bony landmarks, like a tibia that has 1 centimeter of bone all the way around. It appears to have subsided about 1 centimeter or something like that. If they're going to show you a static X-ray, or if they're going to show you loosening, what you really want to see is you really want to see serial X-rays. So implant change in position with time is diagnostic of implant loosening. So if you get an X-ray and the tibia is at 1 degree of varus, and you get an X-ray 1 year later and that tibia is in 4 degrees of varus, and that tibia is loose. So there's that would be something that you would look for. To me, you can look for radiolucencies around the implants, and I think that is important. You can sometimes see if you've got a bad varus knee and you do a decent correction, you have some sclerotic bone medially. You can sometimes see radiolucency underneath the medial tibial tray that sort of gets a little bit worse in the first 6 months to a year, but then it stays stable and you don't really see it progress. So there are some what people call physiologic radiolucency, but you just don't want to see that progressing around the keel and around to the lateral side. You don't want to see a full circumferential radiolucency.
Okay.
And then you're looking for the alignment. You want to make sure overall the knee is well aligned here. I like showing the different relationships here. I look at that a lot. The relationships of the medial lateral epicondyles to the joint line, the overall alignment of the knee, whether or not the components are in appropriate alignment, how much slope is on the implants. If you go back to the previous X-ray, sometimes you can see patients that slope looks appropriate to me, but sometimes you'll see patients the AP looks great, and then you go to the lateral and there's 13 degrees of posterior tibial slope, or you can see that they don't have a lot of posterior condylar offset, meaning they've undersized their implant and taken too large of a posterior resection, and they have probably flexion extension mismatch with flexion instability. Those are important things to notice. You want to see if people have significantly restricted range of motion, you see the Shenton's line in the back of the femur here. Did the surgeon leave a very large osteophyte in the back of the knee that's impinging posteriorly? That can be painful, cause decreased range of motion. You want to look at evaluate the patella for patella baja or alta, and then that's a pretty thorough evaluation. As I'm trying to think about it here, and then obviously you see any sort of any static representation of a dynamic problem, meaning like if you have a knee that is clearly out of balance, like gapped open laterally on a standing AP, then you obviously have concerns for instability.
Yep. And I actually, in the middle of this, I've looked it up because I really thought it was a good article, and it was kind of going through the same things that you were just mentioning. It's how to interpret post-operative X-rays after total knee arthroplasty, and the author name was Kumar, Kumar.
Yeah.
Pretty sure you can probably find it in Google. But that was I think that was a good way to go through the X-rays. Is there ever a time where you consider doing like a CT?
Yes, absolutely. So if somebody has, there's two times that I think about it. Number one, there's a great example here. Patellar instability. I think people have, not everybody, some people have an issue with rotation of their components. And you see that sometimes with symmetrical tibial components. Some people want to maximize tibial coverage. And the way to do that oftentimes is to internally rotate the tibial component relative to where you should have it, which is I like to externally rotate my tibial component to the junction of the medial middle third of the tibial tubercle. So if you internally rotate your tibia, you can upsize your tibial component and you can get great bony coverage, but you have an internally rotated tibia, and I think that leads to a lot of patella maltracking problems. So I typically use an implant that has a symmetrical tibial base plate, but I understand that sometimes you have some posterior medial tibial uncoverage when you're placing your tibial component, and that's okay. This rotation is very important. So I talk about this with our residents all the time, and I think my chief resident class probably is sick and tired of hearing me talk about these things, but looking at the rotation of the femoral component, how do you assess rotation? And I'm an anterior referencing guy, but you can get to the same goal regardless of how you do the knee. And the goal is to have that implant rotated, the femoral component, so it is parallel to the transepicondylar axis. So whether you're using white sides or the transepicondylar axis or the posterior condylar axis, to set your rotation, that's the goal, is to be parallel to that TEA, perpendicular to the AP axis of the femur. And so the femoral rotation is important, the tibial rotation is important. In those cases where someone has pain, or if I get the sunrise view and they've got, it appears like their patella is really either subluxated or tipped way up laterally, or they could have some lateral patellar impingement and they have pain along the anterior lateral knee. That can be a reason to get a CT scan to evaluate your component rotation for sure.
Okay. And I still have a hard time kind of understanding that, just the whole how to assess rotation, and it can get very tricky, but it's something I'm working on. I'm glad that you took a little time to go through that. And I'm sure your residents probably appreciate it, because I don't think it's the easiest thing to grasp, really.
No, it's not.
Yeah, so
I think that the reason is there's so many different ways to do it, and it's funny. Admittedly, a few months into my fellowship, I saw several different ways to do knee replacement. I thought, I just don't understand knee replacement at all, because people are very dogmatic about how they do things, and you hear one person say, "This is the way you do it," and then you hear the next person say, "Oh no, you definitely do it that way. You definitely always do it this other way."
Right.
And they all have good outcomes, and so it just didn't seem to make that much sense to me. So I try to focus on you teaching the goals. Like, what's your ultimate goal for this implant positioning, and then no matter how you decide to get to that goal, as long as you get to the goal, then the knee will turn out just fine. And so some people will just balance the gaps and cut a 90-degree tibial cut, and then set their rectangular flexion gap and go for it. As long as you have a perpendicular cut on your tibia every time, then you're probably going to be fine with that. But you always want to make sure that, especially if you are, more of a minimally invasive type of surgeon, that's hard sometimes to see the epicondyles in your wound. So you've got to be very cognizant of implant rotation. When you make your cuts in a total knee, there are certain clues you have. Let's say you can't see the epicondyles because you're doing a minimally invasive exposure. You can look at white sides. It's not always that accurate. Posterior condylar axis is a little less accurate. But you're cutting, you cut your anterior cut, and you don't see that nice grand piano sign. That could be a clue that you're internally rotated. I think the best last check for me is, because I sort of cut an anterior flat cut first, which sets my rotation, and then I have a 4-in-1 cut block that sort of sits on the end of the femur and anteriorly, and I look at my posterior condylar resection. And for most knees, you should be taking a larger medial cut posteriorly than laterally. So if that cut is even, or you're taking more laterally than medially, then you're probably internally rotated. And so you can see these if you can avoid trouble yourself doing primary knees, but you can also see these types of things on a CT scan. If you get it and you see there's a 7 or 8 or 9 degree internal or external rotation deformity of the posterior condyles of your femur compared to the transitive condylar axis, and that can be a significant cause of pain, particularly if patients, their patella may not be dislocating, but they may be constantly stressing their extensor mechanism and causing lateral patellar impingement and things like that. So Dr. Berger out of Rush has a paper on evaluation of CT scans and painful total knees. That's a really good paper to review